Terrific. Good morning, everyone. Can you hear me okay, Caroline? Shake your head. Great. And let me make sure that I've got yeah, I think I've got the slides under control. Well, it's wonderful to be with everyone. Very grateful for the opportunity to speak with you. We wanted to tell you some new things about what's going on in transplant, and that's what we're primarily going to do. But rather than have them just appear out of nowhere, a new thing without any context, we're going to give in many places some historical context and background to point out what was done so that it makes more sense makes it easy to understand what's being done now. So I'm Elliot here. I'm a transplant nephrologist. And our hope is that Dr. Justin Bellin will follow me, though he is currently in the operating room sewing in a kidney. If he gets finished, he'll be joining us. If not, I feel capable, as I was joking with Caroline, not putting in a kidney, but talking about putting in kidneys. So I will do his part of it if Justin's not able to join us. And finally, Ellen Wells, who's a social worker who's worked in all sides of transplant, will round out the morning. And we have it planned so that while we hope there's something in here for everyone, we're planning 15 or 20 minutes at the end for questions. So that if there's a burning issue in your mind that we don't address, we'll have time to take that question and discuss it. So I first want to talk about immunosuppression because modern transplantation has become the success that it is because of improvements in immunosuppression. And to point out, to go back to the beginning and provide that historical context, the first successful transplant in 1954 at the Peter Bent Brigham Hospital in Boston was between these two twin brothers, the Herricks. And it resulted in the Nobel Prize for 1990 for Joseph Murray, the surgeon. The reason it worked is because the Herricks were twins. And at the time, we did not have sufficient immunosuppression to allow a transplant from any other person, any other pair to be successful. But with twins, because they're biologically, immunologically identical, the transplant worked and the kidney lasted for 8 or 9 years. Interestingly, the recipient lost the kidney because of recurrent glomerulonephritis 8 or 9 years after transplant, which emphasizes that the dual role of immunosuppression in transplant, it's often not only to prevent rejection, but to prevent the recurrence of lupus or MPGN or another immunologically mediated kidney disease. And boy, has there been a lot of progress in the era since the transplant. This chart here shows in yellow the risk of rejection and in the first year, and then in the green is the 1-year survival of the kidney transplant. Again, the Herrick transplant was about a decade before this chart even starts, but you can see in the 1960s, only 40% of kidneys were living through 1 year, and that improved a bit with the introduction of early immunosuppression, azathioprine, prednisone. But then through the long decade and a half or so, from the mid 60s to the mid 80s, very little improved. And then cyclosporin was introduced, and that's when you see this massive improvement in 1-year survival and this massive reduction in 1-year rejection rates. And then since then, we've had an improvement of version of cyclosporin, tacrolimus, mycophenolate, varying other agents and induction agents, and you can see ongoing improvement. And we've gotten to the point now where for a living donor kidney, 1-year survival rates are basically 99%, and there are a couple of percents below that for deceased donor kidneys. So it's been an incredible success story. A lot of it has happened incrementally and hasn't resulted in headlines. I think people sometimes are unaware what an amazing story this is compared to other stories that where one drug solves a whole problem. In this case, it's been very much accretive. Each of the immunosuppressive agents target one of the 3 signals that interfere or that dictate the immune system's response. So in this cartoon, the red circle is the T cell, the green circle, it represents the kidney transplant, which has proteins, HLA proteins, so-called, on the outside. And what generates an immune response where a T cell or a population of T cells would attack a kidney transplant is when the T cell receptor, this red shape and this HLA protein on the kidney transplant interact, and when there's a second signal called signal 2. And interestingly, if you have signal 1 without signal 2, that actually results in the death of the T cell. Whereas if you have both signal 1 and signal 2, then the T cell grows and expands and divides, and that results in the immune system attacking the kidney. Now, inside the cell, there's a series, there's a third signal that leads to the creation of this cytokine called IL-2, which then leads to production mitosis and cell division and growth. And all the immunosuppressant agents we use interfere with one of the pathways in this cartoon. So tacrolimus, Prograf, and cyclosporin are calcineurin inhibitors. They interfere with calcineurin. Corticosteroids actually work along in many places. Sirolimus, also known as rapamune or everolimus, works here. This mTOR pathway, mycophenolate and azathioprine interfere with cell division in the cell cycle. But we only have one drug, and this is the newest, the only new agent that we have in transplant that works on signal 2, and that's called belatacept. And belatacept is the new kid on the block, but unfortunately, this is also indicative of how the price of success, because with 1 year kidney transplant survival being 98, 99%, it's difficult to prove that a new agent is better. And it's difficult to get drug companies to invest in creating a new agent because it's hard to win. It's hard to do better than what currently exists. So belatacept was first approved for use 15 years or so ago. Now, it took about 7 years to prove that it was better than cyclosporin. And this is a graph from the paper that documented that in New England Journal of 2016. On the y-axis here, you have the GFR, so the kidney function, and on the x-axis, you have months since transplant, so 84 up to 7 years. And you can see the top 2 lines are 2 different doses of belatacept being given to patients. And you can see that they have better kidney function, higher GFR at all time points, and even right from the beginning, but also those lines separate as the years go by. So cyclosporin and tacrolimus have some nephrotoxicity. That's one of the great ironies of the drugs. They can injure kidneys even if they prevent rejection. Belatacept does not have that problem. Interestingly, less antibody formation against the kidney as well with belatacept, which is an advantage, and no hypertension, no diabetes. It does not increase the risk of cardiovascular disease, unlike corticosteroids, cyclosporin, tacrolimus. So that's a major benefit, particularly for young people who have kidney failure in their 20s or even younger, where they're looking at a lifetime of immunosuppression. To prevent those metabolic cardiovascular complications is really important. Belatacept, unfortunately, is not a perfect drug. It is associated with higher acute rejection rates in the first few months after you start it. About the first 3 months, we're all a little nervous about belatacept. It's an intravenous infusion, have to get it every month by an IV. It has the advantage that we know the patient's getting it. It's directly observed therapy. They're in a tuberculosis clinic. Sometimes they shine a flashlight into someone's mouth to make sure they swallow the pill, but it's inconvenient. Only Epstein-Barr virus positive recipients, meaning individuals who have serologic evidence of having had mononucleosis, can receive the drug because of possibly an increase in the risk of some lymphomas associated with EBV, may be associated with more severe CMV disease, and it hasn't been tested in some high-risk populations. But it's been a great addition for certain patients. It's a huge boon. However, this is a graph from the USRDS, actually from the OPTN. I apologize, about immunosuppression use across the country from 2010 to the most recent report. And you can see the combination of tacrolimus or Prograf, mycophenolate, Cellcept, and steroids, corticosteroids, remain the most common combination. More than 60 patients around the country, 60% of kidney transplant recipients are on that combination. That's the combination that has gotten us to 98, 99% 1 year graft survival. And so most programs go with success. Also important to remember that another reason that transplant has gotten so much better is that we're much better at preventing opportunistic infections than we used to be. We've learned to use a very old and simple drug, Bactrim, trimethoprim sulfa, to prevent urinary tract infections, pneumocystis, jirovecii, nocardia, listeria, but also we have oral forms of drugs now to prevent cytomegalovirus. So in the early years of transplant, CMV was a terrible scourge. The only intervention to deal with a CMV infection was to reduce immunosuppression. That almost invariably led to a rejection. So patients got into this cycle where they were both infected and they were rejecting at the same time. There's just no way to deal with that problem. Now we have ganciclovir in IV form and oral valganciclovir, both to prevent and to treat CMV infection. That's been a massive, massive step forward. So I'm going to shift now. As I say, we sort of kind of have like a buffet. We hope there's something in the talk for everyone. So that's immunosuppression. I'm going to shift now and talk about living donor transplant. I wanted to point out this pretty famous slide that shows the chances that someone who receives a transplant will not have a problem, either a death or a rejection or loss of the kidney transplant over months after transplant. That probability is related to how long the patient is on dialysis before they receive that transplant. You can see the probability of having event-free survival is higher, the highest, if you receive a transplant before any dialysis is necessary. And the more dialysis that you're on, the more problematic or the lower your chance of event-free survival. Now, transplant is still the best option no matter how long you've been on dialysis. It will still double your life expectancy if you qualify to receive one. It's just that your life expectancy isn't as long the longer you've been on dialysis, and so the risk goes up. And this preemptive transplant performed dialysis is how Alonzo Mourning returned. One of the reasons why he was able to return to the National Basketball Association and receive a kidney transplant. After receiving a kidney transplant, returned to the NBA and won a championship. Now, if you work in dialysis unit, by definition, all the patients you're seeing are already on dialysis, and we never let the perfect be the enemy of the great. And deceased donor transplants or living donor transplants in patients on dialysis are great, but just for the record, it needs to be stated that the kind of transplant I would want for myself or from anyone in my family would be a transplant from a living donor performed before any dialysis is necessary. Unfortunately, nationally, we haven't really made a lot of progress, and that happens very rarely. So from 3 different eras, 2003 up to the most recent data in 2021 from USRDS, you can see that only 3.9% of patients who develop kidney failure in the United States in 2021 received a transplant as their initial therapy. More than 80% received hemodialysis as their initial therapy. The other really interesting thing that's happened in the course of my career is that we have, because of the effectiveness of immunosuppression, we have been able to transplant patients who are not biologically related to the recipient. So this is another piece of evidence of how well the immunosuppression works. Again, the Herrick twins, not only were they brothers, they were twin brothers, and that's why that transplant worked in 1954. In the 60s and the 70s, virtually all donors were identically matched siblings or half-matched siblings or parents. They needed at least one chromosome 6, one haplotype shared between the donor and the recipient because the immunosuppression was not effective. But now with tacrolimus, mycophenolate in particular, the biologic relationship of the donors and the recipient is no longer required. And what that's meant is that unrelated donors, biologically unrelated, spouses, friends, office mates, has gone up, and patients who are biologically related, that number has gone down. Another great improvement in living donor transplant has been the availability of laparoscopic nephrectomy. Patients, an anesthetic has gotten better. Living donors often receive a TAP block, which is a long-acting lidocaine type medicine, novocaine type medicine, put underneath the skin. They walk out of the hospital, usually on day 2, sometimes on day 1, and they're not on opiates. They are comfortable. It's really quite extraordinary. The improvements in anesthesia and surgical technique have greatly improved the experience. The risk of living donation has gone down. Published just a couple months ago, we used to cite that the risk of dying from a living donation surgery was about the same as dying from a cesarean section. The number is 3 in 10,000. The newest data would say that the living donor mortality rate has fallen to 1 in 10,000. So it's now a third the risk of a cesarean section. So what else has happened in living donation? Well, kidney pair donation. So those are what we mostly talk about as colloquially as a kidney swap is now almost 20% of living donation in the United States, mostly to deal with blood incompatibility, but sometimes to deal with HLA incompatibility. There are two independent organizations, the National Kidney Registry and the Alliance for Pair Donation, that broker or organize many of these transplants. At UMass, we work with NKR now. What I would say is that if you're working, every center needs a paired kidney exchange program, or they need to refer patients to a center that has one. Because if someone comes with a blood group incompatible donor and they're just simply told you can't donate because you're the wrong blood type, that is not a standard of care answer in 2024. The standard of care answer should be, we will exchange that kidney for a blood group compatible kidney. And so I really feel very strongly about that transplant programs need to be performing exchanges. And there's a lot of ways to do it. It might not be one of these two. There's other ways they could do it with them internally. They could have partnerships with other transplant centers. But the answer can't be no. The answer has to be yes, we will find a kidney in exchange for your donor's blood group incompatible kidney. So there was another Nobel Prize in transplant related to the economics and the mathematics related around paired kidney exchange. Just a historical note. Alvin Roth, an economist who I think was at MIT at the time, won this Nobel Prize in part because of his work with sharing kidneys. So in the early days of kidney paired exchange, they were swaps. Donor blood group A, recipient blood group B, that's incompatible. We have another pair with the opposite, and there was a simple swap where the A kidney went to the A recipient, et cetera. That evolved pretty quickly into chains where the paired kidney exchange organizations would take what we used to call an altruistic donor. We now call non-directed donor because all donors obviously are altruistic. Anyway, a non-directed donor, someone who didn't have a particular recipient in mind but wanted to do a good deed. That kidney was donated to someone, recipient one, then recipient one's donor went to recipient two, and right down the chain. And you might remember this photograph that appeared in the New York Times of one of maybe the largest chain ever performed. A couple of patients, a donor and recipient, husband, wife, pair of mine from some time ago are on here. I won't tell you who, but they were very proud to be on the picture. It was 60 kidneys or something. It was pretty extraordinary tour de force. But that arranging those chains becomes difficult logistically, and if someone gets ill, it can break the chain, and multiple hospitals and patients can be affected. And so, particularly, the National Kidney Registry has moved away from those long chains, and they recommend that people consider donating in advance. They say they offer vouchers. They call them, and on their website they'll explain this overcomes chronological incompatibility, meaning a donor is ready to donate and the recipient's not ready to receive, or maybe the donor is a school teacher and wants to donate in the summertime and the recipient can't receive a kidney until October. You get the idea. The donor in a so-called standard voucher is when a donor wants to donate to a specific person, and that's the most common. They also offer what they call a family voucher. This is something for a non-directed donor. If they don't have anyone in mind and they donate a kidney, then they can receive a voucher so that if one of their family members develops kidney failure, they could give that voucher to one of those family members in the unlikely event that happens. So this is something nice for non-directed donors. The other thing that some of these the programs are offering, some assistance with lost wages and travel, though there is a national program to help with that as well, and Ellen will mention that. They provide donor mentors, and they will in the unlikely event that a living kidney donor develops kidney failure in the future, extremely unlikely, they will prioritize that person for a living kidney transplant. The problem with all these promises is that these organizations are independent and they're not backed by the federal government. There are no guarantees that these organizations will continue to exist in the future. And so anyone receiving a voucher has to take that into consideration. And in fact, they have to sign a document that acknowledges that they understand that the promise that they're receiving may not be fulfilled. So I wanted you also to be aware of this effort, and that's there's a bill before the United States Congress from a Congress person in New York City suggesting that living kidney donors receive $50,000, $10,000 a year for 5 years in tax credits to donate a kidney. This would only apply to non-directed donors. So if you gave a kidney to your spouse or to your brother, you would not be eligible under this bill. Needless to say, it's called the End Kidney Deaths Act. This is a screenshot from the website. If you wanted to go on and read about it, you could. And needless to say, this is a controversial idea. It's not the first time it's come up. It's been around for a long time. There's only one country in the world that allows paid donation. That's Iran. And other countries have considered it. No one else has adopted it other than Iran. But it's an idea that raises its head from time to time here in the United States. And you all work in the community. You care for kidney patients. At some point, you may have an opportunity to weigh in on what you think about this. So I wanted you to be aware of it. So I don't see Justin, so I assume he's still operating. So I'm just going to plow ahead with his surgical updates. And if he's listening, actually, he'll correct.
Dr. Hare.
You're here.
Sorry. I just got an update that he is coming, but he said if Ellen could just present first, and then he will come back and end it all up for everyone.
Great idea. All right. So Ellen, why don't you take control, and then you can zoom ahead to your slides.
Okay, so well, first of all, thank you everybody for joining us today. I might know some of you from my previous role when I worked as the kidney social worker here, but I've since moved on, and I'm now the living donor coordinator. And I think actually working in both roles has really been a very great opportunity to provide me a unique perspective on what both the recipient and the living donor might go through, such as what are their fears, their hopes, their needs, and their experiences through all phases of the transplant process. But regardless of the role that we serve, we simply want our patients to be well. So if transplant is a medical procedure, some might wonder why we need a social worker involved. So we tell our patients that transplant centers are mandated to utilize social work services. Every team has a social worker. We provide a complete and comprehensive psychosocial assessment. We provide support through all phases of the transplant process. We help provide and secure needed resources and services. We help guide the patients navigate the medical system. And we look to identify any barriers that might prevent somebody from being a good candidate and protect the factor. Most importantly, our goal is to ensure that the patient is safe from both a medical and psychosocial perspective. And for the goal is to improve the patient's life following transplant, not complicate or make it more difficult. We know that, for example, after transplant, patients have a lot more to do for the recipients. They have to take immunosuppressive medications. They have to go get regular labs. They have to have follow-up appointments. So there's a lot more involved. So we here at UMass, we work as a team. Each patient goes through a thorough medical and psychosocial evaluation to ensure the patient's aware of the risks and benefits to transplant and or donation and is able to meet the post-transplant expected medical regime and routine. The social workers, as I said, conduct a full biopsychosocial history. The biopsychosocial is conducted for both the recipient and the living donor. And it's important to note that they each have their own separate and distinct team. Throughout this evaluation, we're hoping to learn more important things about the patient. For example, what is their health literacy and understanding of transplant? Do they have realistic expectations? Do they have the ability to follow medical recommendations and be adherent? Are there any financial barriers? Are there any untreated mental health or substance abuse issues that will cause problems for them? Will transplant trigger psychiatric responses or substance abuse issues for them? For the living donor, emphasis is on whether they are being coerced and what are their motivating factors for donating. And we don't really need to know too much details about the person's financial history and what they have in their bank account, but we really want to ensure that they have the means to be able to cover the co-pays, access their medications. And for example, what happens when a transplant, a person that's been on dialysis has ESRD Medicare? After the transplant, that goes away after a certain period of time. How are they going to be able to access their medical needs? So that's another important thing that we'll be looking for. For donors, we want to really go over how much will the travel costs will be for them. What's the amount of time out of work that they might have, and then that leading to the potential loss of income. We do this to make sure that they can continue to have access to medications and medical treatment before, during, and following a transplant or a donation. And just a side note, you may or may not know, but for the donor, when they come for an evaluation and they are accepted, and then they're in the hospital, they get their aftercare, all those costs are covered by the insurance, the recipient's insurance. But we do mandate that the donors have insurance in the event something is found during their evaluation that they need to be treated for. Then the recipient's insurance would not cover that. So we know, as you all know, being on dialysis is really hard, and waiting for a transplant is also equally. Patients might suffer from anxiety, depression, have a sense of decreased hope. Studies have indicated that 50% of recipients suffer from anxiety or depression prior to the transplant. 50% of transplant patients experience at least one episode of substantial anxiety and depression within the first 2 years of post-transplant. We know that patients would prefer to be well, not anxious and depressed. We also know that some on the wait list may never get offered a deceased organ. We also know that some people might die while waiting. So we must consider then, why then are they not pursuing transplant as much as we would hope? Historically, we have heard from recipients that it's due to maybe feeling guilty, fear, lack of knowledge, limited self-advocacy skills, insufficient support, or simply not having anyone to donate. Living donors mentioned that they're hesitant due to their own possible medical issues or psychiatric issues, their concerns about finances, a conflicting role. What if the spouse of a dialysis patient or a transplant patient is going to donate, then who's going to take care of them? They can't serve two roles at one time. And maybe there's a barrier because nobody asked. The reality is, according to the United Network of Organ Sharing, if asked, 1 out of every 4 people would donate. That's pretty amazing. So then how do we help to remove some of these barriers? Well, for the recipients, we want to educate on the safety of the procedure for the donor. We give them the skills to advocate their needs to others. We encourage creation of a microsite, and we help them to enlist others to advocate on their behalf. For donors, we educate on the risks of the surgery of post-transplant. We evaluate. Donors have a substantial and thorough medical evaluation. We offer financial assistance programs. There's many that I'll just go over in a minute. And we offer the option for advanced donation. And the good news is we now have numerous programs to help our living donors. And each donor, there's just many of them that help with all the travel expenses, food and lodging, and time off pay. There's also Massachusetts has a tax credit that people are allowed to write off up to $10,000. And this slide is just a snapshot of what a typical evaluation would look like for the recipient and the donor. And you see they're pretty similar. However, just please note that they're both each have a distinct team, other than the social worker is the same for all. The financial counseling would be the same, and nutritionists and psychiatrists. The main difference is that the living donors are assigned a living donor advocate, which is an individual that is separate from the transplant team to ensure that that patient is not being coerced in any way. So why should we encourage living donation? Although we might be biased here in transplant, we do feel that all patients suffering from ESRD should be offered the option for transplant as a treatment option if medically warranted. And we feel this way because transplant is the preferred treatment choice. That is because not only is it faster, getting an organ from a living donor is far healthier and has a longer graft survival. Travel for the donor is no longer required, which is a game changer in many cases. Donation is safe, as Dr. Hurst pointed out, and relatively low risk. With the new surgical advances, less recovery time is required. People can get back to their lives and work, whatever they want to do, a lot sooner. And through the assistance of all these programs that we have, minimal financial impact is occurring. So how can we, social workers here, help you in the dialysis centers? We can help arrange an individual or family session to educate on living donation. We can assist family members and their friends to learn how to advocate on behalf of the patient. Sometimes it's really hard for the patient to do that on their own. And we can help patients to create a microsite with the NKR. I think one of the recent claims from the NKR is that people that create a microsite, 20% of those that create one are more likely to get a transplant in the first year after they create one than if they did not. So it's pretty important to encourage patients to do that. So one of the things we'd like to do is learn how to collaborate a little bit more between and have a little bit more dialogue between the dialysis units and our transplant center. And we feel that this is important because it promotes physical and emotional well-being for our patients. It helps patients clarify and understand the roles of the providers from the different centers. I often hear somebody who already have a social worker and it's like, well, I'm glad you do, and I know what you guys do in your roles, but sometimes they have a hard time distinguishing between that. It avoids duplication of services. Maybe somebody's already done a PT1 and we need to do it again. We ensure that resources are secured in a more timely manner. It builds a broader support network for the patient, and it ensures that the patient receives equitable chance and treatment options. So moving forward, what can we do to best serve our patients to ensure that we're exhausting all options for improved health? So when you return to your desks later today, we encourage you to just take some time to think of the patients at your center. To think about what do you believe are the potential barriers for some of them that prevent them from considering moving forward with transplant or living donation. Is it a lack of education? Is it guilt? Is it fear? What can we do to engage and educate the patient to promote transplant and donation? Are we ensuring that all groups of individuals are not being overlooked, marginalized, or excluded? Are we considering cultural, gender, and socioeconomic differences? How can we increase and strengthen our collective efforts to be more collaborative in supporting our patients and to support them through the continuum of care from dialysis to transplant? And how can we ensure increased discussion and communication between Maynard. So thank you. And anytime you want to reach out to any of the social workers, whether it's the living donor social worker or the kidney social workers, we're more than happy to have conversations with you.
Take control.
Okay, can y'all hear me?
Yes.
Great, thank you. I'm Justin Bellin. I'm one of the transplant surgeons here at UMass. I'm sorry for missing most of this. I literally just reperfused a kidney and ran over here to join you guys. We're in the midst of a transplant Olympics today. We have 2 more livers and 2 more kidneys to follow. So I'm just trying to get back to my slides. It's my job to show you guys pictures because I'm a surgeon. So anyway, I think Dr. Hare probably already touched on this, but we're kind of near the cradle of kidney transplantation, being outside Boston, and this presentation is not about us, but it's just, I always like showing the slide. This was the first kidney transplant, and you probably are already aware that these 2 dapper gentlemen here did not require any immunosuppression for this to be, a very sort of resounding success, which was then sort of subsequently followed by decades of frustration as we tried to kind of surmount the immune barrier. But, as of the most recent statistics in the United States, there's about 807,000 prevalent cases of end-stage renal disease, and that goes up about 22,000 annually. So the wait list is about 90,000 folks, of which the median transplant wait time is about 4 to 5 years, depending on where you are in the country, but also depending on your blood type. It can be as early as 3 years. It can be as late as 6 or 7 years. So the surgeons in the country managed to pull off about 26,000 kidney transplants every year, but our wait list is thus about 4 times larger than the supply of donor kidneys. Adding sort of the tragedy of the situation is about 26% of deceased donor kidneys that are procured ultimately end up non-utilized and end up in the waste bin. And so that's obviously a tremendous opportunity, and something that we're always exploring, how to get more kidneys to more patients in a safe manner. So something to just sort of be aware of is that back in 2020, the entire system by which the OPTN and UNOS allocates these organs to our awaiting patients has changed pretty profoundly. Whereas before it was the kidneys were allocated kind of based on a point system, which is still correct, but previously they were allocated regionally, sort of like New England or the Southwest or the West Coast, etc. Now we have sort of more of a model in which state and regional boundaries don't apply. Concentric circles of 250 to 500 nautical miles are sort of drawn around the kidney's donor, and all wait listed patients in that sphere are then stratified by their points, and those points are heavily based on how long they've been waiting, and waiting is sort of defined by either their initiation of dialysis or when their GFR drops below 20, whichever comes first, and when they are identified and evaluated by a transplant program. And then other variables sort of factor into it, but sort of in most simplistic terms, the longer you're on dialysis or the longer you have end-stage renal disease, the more competitive you are for offers. So the purpose of the new allocation was to kind of take down some of sort of state and regional barriers to transplant, decrease disparities, focus on medical urgency rather than patient's location, and improve the matching overall. But just as an example here, when you go 500 nautical miles from us here in Worcester, I mean that includes such urban meccas as Boston, New York City, Philadelphia. So patients are listed on a match run with folks from all of those locations, here in New England. So it's also sort of important to recognize that we have a profound deficit in living donation in the United States, and this is untrue in other parts of the world. There are places in Asia and places in Europe where these numbers are inverted, where they are profoundly more successful in mobilizing living donors and less dependent on deceased donation. But that's certainly an opportunity for improvement in the United States. And, I ask every patient I meet whether they have identified living donors, whether they have any plans to reach out to living donors. So, all of this is to get a kidney transplant to someone. And this is a living donor kidney on the left. I know that because the vessels are much shorter than we get with a deceased donor, because it's generally frowned upon to remove parts of the aorta from a living donor. On the right, this is a pediatric unblocked kidneys. These are 2 pediatric kidneys that can actually be implanted into an adult if there's not an eligible pediatric recipient, and can provide enough renal mass to keep to get an adult off dialysis. So, the idea here is we're always looking to expand the supply of kidneys available. The sort of traditional perfect deceased donor kidney no longer applies as we kind of contemplate how to get more people well-matched organs. This is just the most popular question I get as a surgeon. Every patient wants to know, what are you going to do with my old kidneys? Why aren't you taking them out? And the kidney transplant goes in a much more accessible location, and we're nowhere near the native kidneys. And so we leave those alone with some exceptions, and the most dominant exception is polycystic kidney disease. These are, massive kidneys that impact quality of life for folks, but most kidney transplant patients are kind of tickled to know that they'll spend the rest of their life with 3 kidneys, and sort of be able to brag over their family members that they have more kidneys than they do. So, challenges in allocation, of course, we've already touched on organ shortage. Geographic disparities are very significant. Wait times are very different based on sort of urban density and population density. And so some regions absolutely have longer wait times than others. More packed areas like California, for example, can have longer wait times than New England. And then, there's always sort of an ethical undercurrent to everything we do in transplantation, balancing, fairness, disparity, and medical needs in allocating these organs. But, all of this has kind of come together for us to find new ways to get more kidneys to more folks. As I mentioned, about 1/4 of kidneys are discarded. And the chance of an organ being discarded goes up with age from the donor greater than 50, or such treatable diseases as hepatitis C, which in 2024 we can cure, which was not true a few decades ago. So we now have these donors who we consider outside this kind of conventional criteria, but we consider these to be opportunities for patients. Many of these organs are excellent, and the they just have some disclosure that we have to make and partner with the recipient in understanding what the sort of treatment paradigm is going to be for them, or the surveillance paradigm. But we can get a lot of good kidneys to people sooner. And the organ procurement organizations that facilitate the kidney allocations, in order to combat this discard rate that is quite significant, they are very rapidly kind of opening up sort of what I think of as an orphan kidney, a kidney without a home, and opening them up to transplant centers to give to whoever. And, a lot of the times these are how we call in a 75-year-old who's pre-dialysis or not been on dialysis for 6 months, who, if sort of conventional wait times were allowed to pass, they may be 80 plus and not eligible for a kidney transplant at that time. So transplant programs are becoming more and more aggressive with excellent results, and it's really important you understand that we're not throwing marginal kidneys at folks and burdening them with something that's not going to improve and lengthen their life. And then on top of that, we have these pumps now. And the reason I can get several transplants done today is because of these pumps. Most of these kidneys no longer come in just a cooler with ice. We can put them on pumps that sustain them for 24 to 30 hours outside of human circulation. And that allows us to kind of, create a little queue of transplants that we can get done within a relatively short time frame safely. And those pumps can be cold. Those pumps can also be warm. And there's sort of advantages to both of them. But also important that patients understand that due to the changes in the allocation system, these concentric spheres that I've sort of described to you, if they have the means, it does behoove them to consider getting listed at multiple transplant centers. And, it obviously doesn't make an incredible amount of sense to get listed, say, in, 2 centers in Boston, for example, because they're all quite literally in the same um, uh, region of allocation. But to get listed in New England and to get listed in the South and to get listed in the Midwest, I mean, people do this. And if they have the means to get to another transplant center, we encourage that to be dual listed. And there's a lot of exciting things going on to get more organs to folks. This organization, who I do not work for and I own no stock in, is a nonprofit, 34 Lives, who they are receiving any kidney that has been completely um, uh, exhausted on the match run. Nobody wanted these organs, and they were intended to be disposed of. And they are putting them on a pump and warming them up and monitoring them for function and urine production. And then if the proof is in the pudding that these kidneys work, they offer them back to transplant centers, saying, hey, you guys didn't want this kidney because the donor was older or it had a lot of cysts in it, or anything, but we've got it working on a pump. And if it's working on our pump, it's going to work in your recipient. And this can get some of these kidneys back into circulation. So there's a lot of exciting things going on. And then in addition to sort of extended organ allocation and extended organ criteria, the surgeons are kind of getting fun, fancy new toys that allow us to do the operations less invasively. You've probably at some point heard about robotic surgery in the press, and the robot is a misnomer. It has no autonomous function whatsoever. It is a slave to the console that the surgeon is sitting at. But people are doing single incision kidney donor operations with the robot, just a one incision around the belly button to do the entire operation, get the kidney out. People are doing robotic kidney implantation, so kidney transplant. This is the population that is really benefiting from this modality are the obese and the super obese, who would be denied a kidney transplant otherwise because of sort of the wound complications that come with traditional open surgery. This is allowing us to transplant them safer because of the smaller incisions and the improved visibility of working with the robot. And, because of that, and because of sort of just, again, our willingness to partner with a multidisciplinary teams, nutritionists, physical therapists, social workers, psychiatrists, we are now able to push what we consider to be sort of the reasonable cutoff for transplantation in a lot of areas. So, traditionally a BMI of 40 was sort of our upper limit of comfort for transplantation. And that's become relatively soft. Instead of just turning someone down because their BMI is 41, we're not giving up on them. We're instead referring them to nutrition, seeing what we can do with lifestyle modification. Perhaps, with some of these new metabolic modulating medications, we can help them lose some weight so that they become in a safe range of transplant. We've even gone so far, and this is not, sporadic isolated cases. Transplant surgeons are referring patients for bariatric operations aimed at the purpose of getting them to lose enough weight to have a safe kidney transplant. Sending folks for gastric sleeves, and then if they have an incredible amount of pannus afterwards, sending them to plastic surgeons for abdominoplasties, all aimed so that we can perform a safe kidney transplant. What used to be prohibitive from a purely vascular standpoint, because kidney transplantation is vascular surgery, we're working with vascular surgeons to try to find ways to implant kidneys in conventionally hostile blood vessels. So, all of this is to say that outcomes are excellent for patient populations that previously were considered non-transplantable. And, this is certainly in the news. This was the New York Times in 2021, and it's as a transplant surgeon, I can't go to the grocery store without someone asking me about pig kidneys. And the reality of it is it's not really here yet, but it's coming. Xenotransplant is, I'm hoping to see it in my career. I don't know if I will, because there's still a lot of questions that we need to answer with respect to sort of the human immune system with xenotransplant. But, you know, I think we'll probably see this in many of our lifetimes. So it's a really exciting time for kidney transplant right now. And you know, I'm sort of validated and grateful and fulfilled every day I come to work, as are all transplant surgeons, I'm pretty sure, because it's not an easy job, but it's really the best job. So I think that sort of concludes the surgical update. And are we opening to questions now, I think? Okay, Dana's coming on.
Okay. I think we just
Great.
had
I
one last slide on the end, just
Yes.
Yep. So I just wanted to introduce myself as well. My name is Dana Reisner. I think I've met quite a few people out in the community. If not, I will hopefully meet all of you soon. I'm the education and outreach manager for UMass program. And just I wanted to kind of let you know what my role is. So I am a nurse. I've been in transplant for a couple of decades, let's just say that. And my job is to kind of help facilitate things with you guys, you know, connect with patients, families, all of you all, to help you have a better understanding of the transplant process so that you feel comfortable in speaking to your patients about it and helping us to promote it and working together for that. So that's my little, you know, spiel at the end here. And thank you so much for this opportunity and looking for any questions.
Thank you so much. This is the thank you slide. And then we'll end on this slide. I have one question in the chat so far. I will make an announcement. We have about 7 minutes left of this call hour. And so if you have any questions, feel free to throw them in the chat or raise your hand and you can unmute and ask the team. But the first question in the chat is for Dr. Here. It says, is the family voucher transferable to another family member in the event that one of the original family members for the voucher passes away?
I believe that it is, but I'm not sure. Ellen, do you know?
Yeah, I'm not 100% sure. I was going to actually defer to Wahid.
It is transferable. You get up to 5 vouchers.
So I've just heard through a couple of other people, this is Dana, that it is transferable for up to 5 people.
Wonderful, thank you. Okay. Are there any other questions in for the transplant team? We have some kudos in the chat for excellent presentation. I'll share that. For the attendees on the call, the CEUs for nurses, technicians, and dietitians will be available through iProLearn. We'll be sending out some follow-up communication. That's going to be available starting December 1st. We just have to get this call put into our platform. And then with the holiday coming up, so December 1st, you will be receiving some communication from us on how to receive the CE certificates. And then the CEUs for social workers is actually a possibility. Those will come through UMass at a later date. So you also will be contacted from the UMass team at a later date if you are a social worker who has attended this call. The slides and the recording will be available through either route, likely December 1st and later. Yes. Vicki, go ahead.
Yeah, I had one question about all the pumping and transport. I didn't know whether in the mass there was pumps that are being sent without a person. Do you guys have any, or are they still in a accompanied situation on a flight? I know there were some pilots being done at some of the OPOs where they were just sending trackers and the kidney was going on a pump and just arriving. And so there's a lot of logistics and the pumping is great. I just hoping we can open up more of that, you know, and not have to rely on certain airline carriers, things of that nature. So I didn't know if there was any innovations in those areas.
Am I on? Can you hear me? Yes, we are now in an era in which they're like kids flying for their first time without a parent. they're getting trackers slapped on them, and we often can follow them on our phones. And when they're taking air aviation, and they do have couriers, and typically all this is coordinated by the organ procurement organization in the area. But yeah, they don't have a babysitter anymore frequently. They have a digital babysitter, but not always a human babysitter. The pumps are very stable. They provide a lot of data. So if there's anything going wrong in transit, we can tell by the display that the flows aren't good or the resistance is